Good afternoon, everybody. Welcome back to the second parallel session. This is parallel session 2B, which is the open session. So first of all, speaking, we have Dr. Anastasia Fadeeva talking about injuries and use of healthcare services following violence. Dr. Anastasia is a research fellow at the Violence and Society Centre at City St George's, University of London. Anastasia works full-time as a core member of the Violence, Health and Society, or VISION, Research Consortium. She uses health data, including surveys and administrative records, to examine the associations between violence, physical and mental health, and contact with services. And her research also focuses on violence and abuse against older people. So I look forward to hearing your talk. Thank you.
Hi, everyone. Can you see my slides okay?
Yes, thank you.
Thank you. Okay, thanks for the introduction. So my name is Anastasia Fadeeva. I'm presenting the research that I've done together with my colleagues, Dr. Niels Blom from Manchester University and Sally McManus from City St. George's and NatSen. So this research, so we worked, all of us worked together for the full-time for the VISION consortium, which stands for Violence, Health and Society. This research was funded by UK Prevention Research Partnership, but it doesn't necessarily mean that our views represent the views of UK PRP. So about the rationale for this research, our research is actually focusing on the use of different types of data to understand the distribution of violence in society and the health effects associated with violence. And we know that obviously many victim survivors of violence suffer from health harms, and very often they require healthcare support. And many people, when experience violence, do approach healthcare services, or at least could approach and benefit from healthcare support because of the mitigation of health harms, because accessing healthcare support could prevent from the deteriorating of health in the future. Also because sometimes healthcare is the first point of contact for many people. So victims of violence might not go and approach the police or third sectors, but they might not even share it with their family members if they don't feel safe. But they might disclose the experience to like healthcare providers. So that's why healthcare services can be a very good point for public health prevention interventions for violence as well. However, despite all the benefits, not everyone who experiences violence and related health harms access or use healthcare services. And we know from like mainly qualitative research and some quantitative research that there are some barriers that exist, and that might include factors associated with violence experiences. So, for example, if it's a case of if perpetrators lives in the same home or it's a family member, people might not feel safe to disclose the experience to anyone at all, or because of the for example, they might be afraid of losing child support, or they might feel that it makes the situation even worse. There might be also some demographic characteristics, but we don't know that very well from other studies. As I said, there is quite limited evidence on that. So the last study that was done on that topic when using crime survey was done like almost 20 years ago. There is some research from the US, but US healthcare systems are quite different from the UK healthcare systems. So many people, myself including, use health administrative data from, for example, from emergency departments or from hospitals, and they can be quite good for understanding like health harms related to violence, and looking at the characteristics of people who access healthcare as well. But there's one limitation, is that we can only look at people who actually experience violence and receive healthcare, use healthcare using health administrative data. So we still don't know about people who experience violence but did not access healthcare. So that's why surveys can be quite a good source of information, because not only we learn about people who experience violence and access healthcare, but also potential about people who experience violence and did not receive medical help. And so the most probably detailed source of information on violence in England is Crime Survey for England and Wales. Importantly, it provides information about quite detailed information about violence experiences, about some health harms, but also about what the sort of different types of support that people received following the experience of violence. So for this study, we used a crime survey for England and Wales, and the aim was to understand the gap in inequalities in healthcare usage following violence victimization. We also specifically looked at the individual socio-demographic characteristics of victim survivors and contextual factors related to violence victimizations to look at the associations with the severity of injuries, with receiving medical attention, and also we look at whether the severity of injuries moderated relationship between violence-related characteristics and individual factors and receiving medical help. So the main data source was, as mentioned, Crime Survey for England and Wales. We used the main victimization model. There is also an additional model that is specifically looking at domestic violence, but we'll use the main victimization form. We used 12 survey waves, so between 2010 and 2024, excluding COVID times thing. So the crime survey for England and Wales collects data from all adults aged 16 and over, and specifically ask about violence victimization in the last 12 months, and that includes the use of physical force. So that mainly included cases when people experience physical violence and also some types of sexual violence. So for each participant in the survey is giving up to 6 victim forms. So in cases when people experience more than one incident of violence, so they can complete up to 6 different forms for each of the cases of the violence victimization. The measures we look at were receiving medical help following violence victimization. So that included medical help from emergency departments, from secondary help, from dentists, from ambulance and first aiders. And people could also choose multiple options if they received help from different providers. Also looked at injury by severity. So this is like different types of injury we look at, and we categorize ourselves just in 2 categories. So kind of minor injury, so more superficial injuries, like bruising and scratches, and major injuries that included like broken bones, internal injuries, all facial and head injuries, and different cuts as well, and stab wounds, and all the others. We also look at victim-perpetrator relationship, and included stranger and acquaintances, and the case of domestic violence. Also number of perpetrators, so either single or multiple, weapon use, location, time of day, time of week. So time of day, sorry, was either weekend or weekday. Time of week and time of day was either before 6 p.m. So between 6 p.m. and 6 a.m. it was a nighttime, and between 6 a.m. and 6 p.m. as a daytime, and survey year. And we also included different socio-demographic characteristics, including age categories, gender, ethnicity, relationship status, education, and employment status. So in terms of analysis, it was so this basic descriptive analysis was first done to look at the characteristics by the type of injury. We also used multi-nominal logistic regressions to look at the associations between injury severity and violence-related and socio-demographic factors. We used logistic regression to examine the associations between receiving medical health care and injury, violence-related and socio-demographic characteristics, and also use interaction between injury type and the other socio-demographic and violence indicators for receiving medical help. Based on the descriptive analysis, we found out that over 9,000 there were over 9,000 victim forms related to physical violence in this 12 waves I mentioned. More than a half of victim forms belong to men, and most of them were of young age, so almost a half were people aged less than 30 years old. Majority, so more than a half were single. More than half of violence incidents also resulted in some kind of injury, so either minor or major. Almost a half involved stranger, a third involved an acquaintance, almost a fifth involved in a domestic relation. For 2/3 of violence incidents, there was one assailant. Almost a half victims with major injuries received medical help. And so white British people reported more minor than major injuries. For other ethnic categories, there was now a significant difference. In terms of factors associated with major injuries, they're all presented here. And probably, so only significant factors here. And probably, so the quite interesting findings was that so people who experience violence from in domestic relationship and from acquaintance were more likely to experience major injuries in comparison with no injuries. Its other factors included having multiple perpetrators, expected if it was weapon use, and also people were more likely to experience major injuries than no injuries. If the location of the violence incidents was work and recreation facilities in comparison with home, if it was done if it was done in the if the violence case happened in the evening. So also, sorry. Also, if it was if men were more likely to report major injuries, people of younger age groups and the youngest age group and the oldest age groups were more likely to report so less likely to report major injuries. And also people who were single and separated or divorced in comparison with married people were more likely to report major injuries. And people with no or other education qualification were more likely to experience major injuries. In terms of receiving medical support following violence victimization, the important predictor was injury type. As expected, major injury predicted people experienced major injury were more likely to receive medical help. If the violence was from multiple perpetrator, if the weapon was used, if the location of violence was workplace in comparison with home. Again, so men were actually less likely to receive medical support. People who was from the oldest age group, 70 plus, and Asian British people were more likely to receive medical help in comparison with other ethnic groups. And people from the so people who had A-level or similar qualification were less likely to receive medical help than people with higher education. And also interesting, we look at some interactions. Actually, we look at all the interactions, but there's some of the significant ones right here. And again, it's quite interesting that I mentioned before that people in a domestic relationship were more likely to experience major injuries, but also interesting when people experience violence in domestic relationship and experience major injuries, they were less likely to receive medical help than people who experience violence from from strangers or acquaintances. Also, people who experience violence from multiple perpetrators and experience major injury as a result, they were also they were more likely to receive medical help than people who experience major injury from single perpetrator. For location as well, there was a significant finding. So people who experience violence in the workplace and experience major and minor injury as a result, they were also more likely to seek medical help than in if it experienced a major injury at home or minor injury at home or at recreation facilities. And for gender differences, so there was significant difference between men and women for minor injuries. So if men experience minor injury, they were less likely to receive medical help than women, but for major injury, there was no difference. So to summarize, so kind of the most interesting and important findings that we found were that victims were more likely to be men of a younger age and experience violence from a stranger, as it was based on the descriptive analysis. Half of the victims with major injuries did not receive medical attention. So that's quite important as we think, because I would say as major injuries, they are more likely to progress and lead to more severe health problems in the future. So that's quite important to know, that people with major injuries often do not seek or don't receive medical help for some reason. People who experience violence in domestic relationships were at the highest risk of receiving injuries, but they were also less likely to receive medical help than people in other types of relationship with the perpetrator. And that's it. Thank you for your attention.
Thank you very much. So we're moving on to the next presentation. So if you could stop sharing, please, Anastasia. So our next presentation is about building a synthetic population to assess the health impacts of local climate change policies in England, presented by Andrea Serna-Castano and Eleonora Fichera at the University of Bath. Andrea is an applied environmental and health economist with experience in experimental design, data analysis, and interdisciplinary research. She's a research associate at the University of Bath's Institute for Policy Research, where she collaborates on projects related to food regulation, sustainability, and commercial determinants of health. So yeah, please go ahead, Andrea.
And thank you, Alison. So I will start sharing my screen.
Thank you.
So yeah, as you said, I will be presenting today the synthetic population for climate change at a local level. And this is part of a work that we're doing with a consortium that is called Local Health and Global Profits, which in turn is like a part of a bigger network. And we're working closely with local authorities to try to help them in different set of topics to improve public health at the local level. Now, the links between environmental determinants and health have been widely established in literature and also by institutions like the World Health Organization. It has been estimated that approximately 24% of all deaths are attributable to preventable environmental risk. And there is an equity dimension that makes this worse when top 10 wealthiest individuals contribute a lot more to the global warming than the average person. Now, in terms of the sectors and who contributes the most to this problematic, we can see that according to the greenhouse gas emissions in the UK, the domestic transport contributes to 30% of those greenhouse emissions. And it has been the sector that has had the least reductions when we compare to the 1990s values. Now, the net zero strategy has identified that 82% of total emissions are within the reach or the scope of local authorities. So they have identified local authorities as a big player in climate policy. In 49% of the local authorities, transport is still the top emitter, and they do have decision-making power in terms of land use, planning, waste, transportation, and employ impact assessment to make some of them decisions in terms of environmental, health, equity, impact assessments. But sometimes it can be difficult for them to include those long-term effects, especially for climate policies. And there are some structural barriers in terms that they don't have enough budget, they don't have enough workforce, so there's capacity, and in terms of the skills that are required also to include those impacts in their impact assessments. Now, what we think is needed is to include like more information to make optimal decisions at the local level, even with those constraints. And we think that it would be important to have a high resolution population data that would inform those decisions for us to be able to identify those people that are more vulnerable in terms of health or that are more exposed, and also to guarantee that the solutions or the alternatives that policy alternatives that we evaluate for climate change are also equitable. Now, there is a problem in terms of the data available. This data at a high resolution is usually confidential, is protected, and sometimes not even available for local authorities to use. So that's where we think that maybe synthetic population could come as a solution or an alternative to fill that gap. So a synthetic population have been around since the 90s, and they are like simulated individual level data sets. They're like made up or fake populations that look like the real populations. And we can create them by using data from the surveys, like for example, Understanding Society with overall population numbers from the census. Now, we will talk more about this later, but in this case, we used the method called combinatorial optimization with simulated annealing, and we did that because there was already a lot of studies that had comparative of the different methodologies, and they evaluated that as the best. Now, the objective that we want is to build a synthetic population that can serve as the basis to access health impacts of local climate change policies and to be used in those impact assessments to provide information for decision-making at a policy level. Now, for that, we want to first determine what are the characteristics of those constraint variables that we need to create that population that can lead to a better performing final synthetic population. And we want to evaluate the ability of those different constraints to sets to reproduce spatial patterns, and also in environment, but also in health relevant variables. And the alignment between those health outcomes and environmental exposures, that those correlations that we have evidence in studies are also present in the population that we built. Now, there have been previous exercises and examples of synthetic populations, and we have for Great Britain, England, Canada, and even a global synthetic population. They have mainly focused on socioeconomic and health, and there has been one that has focused on circadian activities. They have mostly included variables around like demographic, economic, social, and some housing variables, and have used a mix of the methods that are available for synthetic population. Our contribution, I guess in this case, would be to evaluate a little bit more closely what are the variables that we choose as constraints and when we are including them in our population, and also to include environmental exposure data. In this specific case, we'll focus most on transportation or specifically on air pollution, but we do plan to expand for flood risk and heat waves in the future. And we want to have an emphasis on the distributional health impacts that those problematics can have. Now, a synthetic population has 6 general ingredients. The first one would be the geographic boundaries. A second one would be like the data sources that we use, the constraint variables that I have already mentioned a couple of times, the methods that we employ to build that synthetic populations, the outcome variables that we're interested in, and the validity of the measures. Now, synthetic populations can be used to evaluate or to study social patterns, right? But it can also be used for microsimulation methods. So that's where the outcome variables become really important for us. Now, the geographic boundaries that we chose were England, and we chose it for a population of over 16 years old. We focus on data that is at a lower super output area, which comprises usually 400 to 1,200 households. The data that we use is the 2021 census for England and the Wave 14 of Understanding Society. For the air pollution data, we use a map of the modeling done by DEFRA on nitrogen dioxides. Now, for the choice of the constraint variables, we had several elements that we took into account. The first is that we started with variables that were both present in the census and in the Understanding Society. Then from then, we wanted variables that had a high enough response rate in Understanding Society. And we included variables that had a really good fit with respect to their distribution in the census and Understanding Society, like so that the distributions or the proportion of how they are in like of the categories are similar within them, and that added new information to the population. So we took away variables that were very highly correlated within themselves. And this is the final set of variables that we chose. So we have sex, age, ethnic group, highest level of qualification, economic activity status, general health, and air pollution. We had to create a category that was the same for both of the data sources. So these are not the categories that are in Understanding Society of the census. It's like a mix of the two that best fitted our choice. So the final variable is the only one that is not included in either of those data sources, which is air pollution. In this one, we calculated with the map from DEFRA, and we intersected it with the LSOA boundaries, and like that we estimated the proportion of the population that was exposed or unexposed to a specific level of air pollution according to the values set by the World Health Organization, which in this case I think was greater than 10 micrograms. Now, this is the outline of the synthetic populations that we built. So we started with a very simple synthetic population that only included the demography variables, which in this case is age and sex. And we increased the number of variables until we had a complete set with the sex population that included all the variables available. Now, in the method, as we had explained, we use the simulated annealing, and we use the flexible modeling framework, which is a software that implements that model. And what it does internally is that it takes a sample of the survey, and it takes a subset of that survey that fits the size of the LSOA. So it starts by the first geographical division, and then it fits it into the size of the census has established for that LSOA. And it takes that subset and it estimates the goodness of fit. And then if the fit is closer to 0, that means that there's a really good fit between the two elements. And to improve that fit, what it does is that it swaps one individual from the selected subset and from the overall sample, and it takes another one and it estimates that subset again. And if the fit improves, then it keeps that individual. If it not, then it swaps again. And it does that until it reaches a maximum level of iterations or until it reaches a threshold of goodness of fit. Now, the outcome variables that we were interested in were mostly health conditions that were related to air pollution data for this specific case, and that were also available in the understanding society so that we can then verify them when we had our synthetic population. And this include conditions like asthma, chronic bronchitis, diabetes, lung cancer, among others. Now, we had to structure some validity measures to verify that the population that we were producing was both internally solid, but also that externally it would produce results that would help us in our modeling strategy. For the internal validity, we chose the percentage of classification error, which just checks the proportion of people that are misclassified in the synthetic population with respect to the census. Now, for the external validity, we compared the outcome variables, which in this case are the health outcomes, with respect to external data sets, and that can be the health survey or the health episodes statistics for the specific condition that we want to check for. In this case, we will see an example with the asthma prevalence at the LSOA level. Now, the first result that I wanted to show you is the internal validity. So in this case, we have all the 6 synthetic populations with the survey sample attached to them. And we can see the mean percentage of classification error of the included variables. So only the variables that were included in each of the synthetic populations and of all of the variables that we took into account. And we can see that there's a decrease in the percentage of classification error when we introduce a new variable for all the synthetic populations, except in the synthetic population number 5, which we include the health variable. Now, it does improve the overall health, mean percentage classification error for all the variables. So it does still decrease, even if it increased a little bit only for the included ones. When we see this at a variable perspective, from the error by variable, we can see how the inclusion of the variables affected those that were included and those that were not included. So adding a new variable did not have an effect on the previous variables that had been already included in the synthetic population, but it did decrease the classification error of those that were not included. And as you can see, the general head is the one that had the least percentage of change when we excluded and when we included. So it didn't actually increase so much, decrease so much the percentage of classification error. Now we can also check this in terms of the geography, so how the errors are split by LSOA. So we can see, for example, in this map, the mean percentage of classification error, how it is spread across all the LSOAs. And we can see that internally, it seems to have a good fit in terms that most of them are in the yellow or green light, with only a couple of dark green spots. But then the story changes a little bit when we introduce the external validity. So when we check the external validity and we compare the asthma proportion of the external versus the synthetic population, we can see that if we compare like the first synthetic population versus the sixth synthetic population, which is the more complete one, we can see that in the first, it's not really well estimated. And then when we see the sixth population, there is a minor improvement and they're more aligned, but there we are still undervaluing in the proportion of asthma in the population. So we are still have like a
last minute, please.
Yeah.
Last minute, please.
Thank you. So there's still some improvements to be done in the synthetic populations in order for them to be externally valid. So as a conclusion, we identified that there was a gap in the literature and how we choose those constraint variables. Often it's just based on data availability, but then maybe we need to think a little bit more about a framework for inclusion of those variables. In terms of the internal validity, we thought that there's improvements with the sequential constraint addition of each of the variables, and we have the greatest gains with education and economic activity. And general health had a slightly reduced in the model fit. Adding constraints did not reduce the accuracy of the earlier variables, and the last most detailed model did improve the fit across all the LSOAs. But in terms of the external validity, the asthma estimates only saw a marginal improvement, and this suggests that maybe we need better data that is aligned more to the health constraints or more richer health data. We will check this with other conditions that are not only asthma, but all the other health outcomes that we have showed before. Now, for the next steps, what we want to do is to include more environmental risk, as I mentioned, flooding and heat waves, to strengthen the external validation using other linked data sets that have the joint health distributions, and to integrate the population into a dynamic microsimulation model that can have for long-term policy evaluation that can include that information in environmental health and equity impact assessments at the local level. And that's all from me, just acknowledgements of who supported this work. If you have any questions or know of any papers that could be relevant to this work and is interested, please send it to me in this email. And thank you so much.
All right, thank you very much. So we're moving on now to Joseph Lamb to talk about examining the use of ethnicity at different levels of aggregation using I-MAIHDA. And Joe Lamb has a strong interest in the equitable generation and use of data to improve the well-being of all. His research focuses on identifying biases and methods and analytical practices using linked administrative data and longitudinal population data to tackle long-standing health inequities. And Joe has a background in psychiatric epidemiology and psychology. So yeah, please go ahead.
All right, thanks a lot, Alison. Just checking, you can see my screen all right?
I can see your slide, yeah, your first slide.
Perfect, thank you. So today, instead of presenting a typical research study with all of your methods, results, and findings, I want to really invite you all to come on this sort of more reflexive journey of trying to understand, solving the problem of aggregation, of using different ethnic categories in our analysis. You might think, okay, it must be well established long ago that we should try to use more disaggregated ethnic categories when possible, as a more inclusive data practice, but also knowing that there are vast differences within sort of the broad ethnic categories. But as part of my PhD, I did a sort of bibliographical review that looked at the top 1% cited UK health research papers that have used ethnicity in their research as a predictor or a covariate. But unfortunately, the sort of number of categories, the wordings, the aggregation, in particular the theory that people have used it within the analysis was often highly varying and unclear, to say the least. So, but in the extension of sort of intersectionality framework and thinking about how variables interrelate with each another, how does our existing understanding of using more disaggregated ethnicity, well, operates in that space? So this paper that I'm presenting really is an exploration in this space, trying to see, ideally compare. Well, in my biased head, it would be demonstrate that using more disaggregated ethnicity helps us understand the phenomenon we are hoping to model and or better fit our data. So a huge thanks to my co-authors, and especially Erin, who I've nicked a lot of his slides in helping me put this together. But first, this is a sort of brief conceptual framework that I used a lot in my own work in helping me understand the sort of life cycle of data, how it was born out of behavior, how it's captured, conceptualized, measured. In my work, I've mostly focused on data linkage methods and analyses, and all these sort of problems that our two previous speakers have very nicely identified and highlighted. But my talk today focuses on the last bit of my pipeline, which is the analysis and the researcher's choice in aggregating and designing and interpreting and modeling what our data could tell us. So this is part of the, if you may, the recontextualization of the data that got into our hands. So I don't think the concept of intersectionality is too unknown to us. Yet Collins, one of the earliest speakers on the notion of intersectionality, did describe it as an emerging critical social theory. I think I partially agree, as the sort of the tools and ability for more quantitatively focused researchers to look at intercategorical intersectionality has improved quite tremendously over the past, I guess, decade. In the UK as well, and thanks to prominent methodologists like Andy Bell, who sort of is leading on a lot of the UK-based exploration on I-MAIHDA and its related methods. But the concept of intersectionality really is the whole is greater than the sum of its parts, that the interrelated variables or systems of powers may give us observations that's beyond our sort of fixed or sort of axiom-based understanding of each individual categories. So the data set that I'm using to explore this methodological question is the evidence from Equality National Survey, a survey of ethnic minorities during the COVID-19 pandemic, the EVANS study. And the evidence cohort comprised of around 14K UK adults. They were surveyed during COVID. They included a booster sample of around 9 to 10K ethnic minority participants. And they have gone out of the way to recruit people from a range of ethnic minority settings, including Roma people and others who wouldn't normally be well represented in other cross-sectional surveys. And it gave me a really nice opportunity to have this disaggregated, properly captured ethnic identity where I could then use to sort of compare if we've used a higher aggregation versus a more disaggregated ethnicity, how would things differ in my model? But to preface this, we should know that ethnic categories are not universal, and there is no power in ONS by defining the sort of white, other, Asian, Black, and mixed groups. They are different over place and over time. I think we as in quantitative researchers using surveys sometimes somehow have a tendency of trying to be akin to or uses these standards for I suppose comparability, but without I guess make use of the power that we have in A, disaggregating our data, or B, even interrogating whether the labels that we are using truly make sense. So the the graph I'm showing you is part of the hopefully up and coming Lancet Commission on Global Racism and Child Health. And I've looked at all of the latest censuses across the world and looked at how different ethnicity and race and caste, indigenous status, etc., were being asked in national censuses. This is only a cross-sectional snapshot. And if you look at, say, the UK, the number of categories and how it was asked changed significantly over the past 30 years when it was first introduced in 1991. And in administrative data, the same problem remains across health systems, across different modes of data collection, levels of ethnicity we were able to collect differs, and more so in research, how they were aggregated and analyzed. So thinking more closely back to our notion of intersectionality and interaction, that the key, I guess, strength of being able to look at the multiplicative effect of multiple variables on our desired outcome is ripe, is great. But the ways in which people can model that hasn't been as easy, and there are many emerging, I guess, approaches, and one of which is I-MAIHDA, which I don't think I'll have the time to go into the details of the actual methods, but the concept is pretty much a multi-level modeling, while the level 2 model, level 2 comparison is defined as intersectional strata. And when Claire Evans designed it, it is pretty much inspired as a social theory focused approach into understanding conditions in which people are living in. So by intersectionally strata, it could mean it means a researcher-defined combination of socio-demographic variables that individuals are situated in. So that's one of the typical usage of I-MAIHDA. So for example, it could be living as a woman and an ethnic minority who lives in a rural area. So that's a sort of strata that defines people in that group. And each of these stratas are defined and compared in the I-MAIHDA model. And there has been simulation work in how this model could be applied with demonstrated stability, parsimony, and shrinkage to allow for even small social stratas to be estimated at a certain stability. Andy Bell has a great tutorial on this, and which is, I think, freely available online. So I would strongly recommend when I don't explain this clear enough. Here are some equations for people who like them, myself included, and that describes the key sort of statistics that I will be presenting, which is the comparison between the null model, which is the model that only looks at between stratum variance explained by the intersectional strata, compared to the main effect model, where we simultaneously adjust for the individual variables that make up or defines the intersectional strata. The key number that we are interested in is the VPC, but also the proportional change in variance. So that would tell us the percentage reduction in between stratum variance attributable to the additive main effect, which means the VPC that's left, we can sort of think it as these are the remaining intersectional effects that could not be explained away by the main effect. Okay, so in a moment, I will be comparing two MAIHDA models, one with the 21 category ethnicity and defining the intersectional stratas, and one using our good old Big Five ethnicity as our defining variable for the stratas. And by comparing whether the two models still captures which model is better in explaining or identifying intersectional models, then we can sort of help us differentiate the added benefit of using more disaggregated ethnicity. So here's a sort of conceptual description of my model. The outcome was the experience of racism. I took it as a lifetime experience throughout the. So in Evans, they could respond whether they've experienced racism in the past 12 months and a different sort of time frame. I've aggregated that to create sort of a lifetime experience variable. And I've used sex, age, and UK nationality in defining, and ethnicity to define my social strata. So that would mean 2 categories times, in my data, 5 categories times 2 categories times 5 or 21 categories to give me up to, say, 400 stratas for the 21 category model and a bit less for the 5 category model. And overall, in the Evans study, over 65% of the participants has reported experiencing racism in their lifetime. So it is a, unfortunately, very common experience, probably heightened as it was during the COVID pandemic. And we have, so on the right, these are just a description for, so each straight line represents each strata that you can see most of the stratas, people in those stratas experience a high level of racism. And the inequalities appear to be slightly less in the 5 category model. But not very clearly described in this graph was that young males and females identified as having Black Caribbean, Black African, and mixed ethnic backgrounds, regardless of nationality, have disproportionately high lifetime prevalence of racism, double lifetime. And here are my main comparisons. Sorry, speeding up because I'm aware of time. So on the left, you can see the 21 category model. Logistic model 1A is the null model, and 1B is the main effect model. By looking at the proportional change in variance, you can see the 21 category model, the remaining intersectional effect is modest at 2.4%, whilst for the 5 category model, there are significantly larger VPC that has remained, so intersectional effect that couldn't be captured by the main effect. So what does this say? So these are just visualizations. So we appear to see that there are bigger interaction effect in coarser models than in more granular ethnicity models. How do we interpret it? So if we spend a bit more time looking at the data, then we would see that the appeared sort of better fit or better performance of the intersectional model in the 5 category definition mostly comes from inflation because of the lack of clarity or lack of information that has been conveyed using the broad categories. A great example is the white group, which includes white, other white, and also includes gypsy travelers, for example, in the UK ONS particular definition and framework. And the experience of those 2 groups within the same category vastly differs. And that information coming from the poor, I guess, discriminative power of that label mimicked itself as contribution to the intersectional model. So I suppose if in our very limited of time, if we need to take away one message, it would be using more disaggregated models, 1, fits the data better and helps us explain things. And 2, if you only have access to sort of coarsely defined ethnic variables, you might want to be careful in interpreting what you see, because the intersectional effect could come from different sources. There are some other comparative studies. This is in the US population that's only specifically broken down the Hispanic/Latino categories into the further decompositions. And they did not observe the same, I guess, ambiguities as my study, but also they've only the only comparison was between Hispanic Latino and its subgroups. So we did not have any subgroups for non-Hispanic Black, for example. I do recommend you to look at their paper as well. I have some other things, but I don't think we have time to cover it. So I'll say my thanks to the Evans participants, to the Evans group, and the UK Data Service for allowing me access.
So thank you very much. So the next presentation is from Mikaela Bloomberg, and it's about demographic and socioeconomic risk factors for pain progression and recurrence in middle-aged and older adults, a multi-state analysis. Mikaela is a senior research fellow in the Department of Epidemiology and Public Health at UCL and a member of the ELSA study team. And a central focus of her work is understanding how demographic and socioeconomic factors influence health trajectories and contribute to disparities in older age. So yeah, please share your slides.
Okay, perfect. All right, so I'll kick paper where we looked at, as Becky said, as Alison said, demographic and socioeconomic risk factors for pain progression recurrence. Okay, so for some background for this paper, it's very well established that there are demographic and socioeconomic factors that are.
Okay, so I'm on the background slide now.
Okay, I guess yeah, that works. Okay. Okay, yeah. So there's a lot of well-established risk factors for pain onset. So we know that women and people of less with various markers of socioeconomic disadvantage are more likely to have pain, but a lot of these long-term pain conditions are very dynamic. So people have pain that recurs, it gets better, it goes away, and it can occur over a very long period of time. And the issue with this is that a lot of the evidence base as it exists currently doesn't allow for the recurring changes in pain. So a lot of them use these sort of trajectory models, which are very flexible, but just because of data sparsity issues, they kind of tend to identify relatively linear trajectories. So things that are kind of stable high, stable low, increasing or decreasing, which doesn't really take into account the fact that pain is very individual. It's highly variable. And partly as a result of this, the evidence for demographic and socioeconomic associations with pain worsening recurrence is very mixed. So we know that, so in general, really only women have consistently worse pain trajectories. All sort of evidence for any other of these sort of basic demographic and socioeconomic characteristics is surprisingly mixed. So the objective of our study was to identify the demographic and socioeconomic characteristics of individuals at risk of pain worsening and recurrence, and to do so using methods that that sort of respect this highly individual and nonlinear nature of pain. So if you could go to the next slide.
Yeah, data source.
Okay, great. Okay, so we used data from the English Longitudinal Study of Aging, which I'm sure most people are familiar with, just in case anyone still isn't. It is a nationally representative study of adults aged 50 years and above and living in England. We have data currently available from 10 interviews that are occurring between 2002 and 2021. And at each wave of ELSA, participants are asked to report whether or not they experience pain, so whether pain troubles them most of the time. And also asked to report on the severity of their pain, whether it's mild, moderate, or severe. Okay, so can we go to the next slide?
Mm-hmm.
So in this particular study, we used data from about 9,300 ELSA participants who are aged 50 to 98 years, and who reported mild, moderate, or severe pain during the waves 1 to 10. And for this study, we considered the baseline wave to be the wave at which they first reported pain. And we can go to the next slide.
Okay.
So then we constructed this sort of multi-state framework for looking at transitions between various pain states. So we defined 3 states here. So people could, we categorize people with moderate to severe pain as as being in state 1, people with mild pain as being in state 2, and then we also had a no pain state. So everyone started in either moderate severe pain or mild pain, and then they could transition between all of these different pain states. And what we do is we use these multi-state models, which essentially they simultaneously fit a bunch of survival models to be able to look at which characteristics make people more likely to make each of these transitions. So in particular for this analysis, we were very interested in these transitions between moderate severe pain and mild pain, so back and forth there. Because so that's pain worsening and pain improvement. And then we're also interested in transitions between the moderate severe pain and no pain. So that's pain remission and recurrence. And we focused on those sort of moderate severe pain transitions versus sort of the mild pain transitions, because obviously moderate severe pain is sort of more likely to have implications for health and well-being. Okay, so the next slide. Which,
yeah, the DAG.
Okay, yeah. So I did. I've this is one of the ones that I changed. So we examined a couple of demographic and socioeconomic characteristics, including age, gender, marital status, education level, and wealth. And then we wanted to basically sequentially build up these models so that we are able to look at the effects of these various demographic and socioeconomic characteristics, the associations with these pain transitions, adequately accounting for confounding without adjusting for models down the causal pathway. So we did this by constructing this DAG. So we made some sort of assumptions about the direction of causality, all that sort of thing with each of these demographic and socioeconomic characteristics. And that led us to build four different models. So the first model was an age and gender only model. We then had a model which was age, gender, and education, then age, gender, education, and marital status, and finally age, gender, education, marital status, and wealth. Okay, so the next slide, please.
Yeah, the results, table 1.
Okay, great. So, so we had a very similar median follow-up period for both of the pain groups at baseline. So the moderate severe pain group had a follow-up period of around both the moderate severe pain group and the mild pain group both had follow-up periods of about 9.5 years. Somewhat as expected when we looked at baseline, the moderate severe pain group tended to be older than the mild pain group. They were more likely to be female, more likely to be single. They were less educated and had less wealth than the mild pain group. And then the next slide.
Okay, your hazard ratios.
Yep. Okay. So these show plots for hazard ratios for transition probabilities. So basically on the left panel is the pain worsening. So this is people going from mild pain to moderate severe pain. And then as you would interpret any hazard ratio, so you have the null line on the 1 there. So a hazard ratio of greater than 1 indicates that that characteristic makes people more likely to make that transition. And then we also have pain improving on the right-hand side, which is people moving from the moderate severe category of pain to the mild category. So to start with pain worsening, we found that age, education, marital status, and wealth were associated with pain worsening. We found that older participants were more likely to have worsening pain. Individuals with higher education were less likely to have worsening pain, and single participants, relative to single participants, people who were married or partnered, were a little bit less likely to have worsening pain, although it was sort of marginal. And the same with wealth. We saw sort of this marginal association with wealth where wealthier people were less likely to have pain worsening. So we'll do the next slide.
Yeah.
So for pain improvement, we saw that gender, education, marital status, and wealth were all associated with improving pain. So we saw that women were less likely to have pain that improved over time. More educated people were more likely to have pain that improved over time. Single people were, or relative to single people, married and partnered people were more likely to have pain that improved over time, and wealth also made people more likely to have pain that improved. So if we go to the next slide.
Okay.
So in these two plots show remission and recurrence. So going from moderate severe pain to no pain, and then from no pain to moderate severe pain. So on the left-hand panel, we have remission. So we found that age, gender, education, and wealth were associated with remission. And we found that in older participants were more likely to have pain that went into remission, which was a little bit of a curious result that we were interested to see. And then women were less likely to have pain that went into remission. More educated people were more likely to have pain going into remission, and higher wealth was also associated with a higher probability of going to remission. So for the next slide.
Okay.
So now we're looking at pain recurrence. So this result seemed a little bit counterintuitive, or this result made sense a little bit more, but was a little bit counterintuitive along with the remission. We found that older participants were more likely to experience pain recurrence, but also more likely to experience remission. We found that women were more likely than men to experience pain recurrence, and individuals with less education with more education were less likely to experience pain recurrence. Okay, so next slide.
Sensitivity analysis.
Okay, great. So when we recategorized, we did a couple of sensitivity analysis to examine the robustness of our results. So we recategorized the pain states as has been done in previous sort of multi-state analysis and pain severity, where we had a no mild pain category rather than a moderate severe pain category, and we found that results were very consistent. We also considered only the individuals who reported pain at the following, who reported pain at a wave following the baseline wave. So they had pain at 2 consecutive waves. This was because, so in ELSA, the biggest limitation of sort of doing sort of chronic pain research in ELSA is that it doesn't regularly assess the duration of the pain, where chronic pain is generally considered to be pain lasting 3 months or longer. So by doing this analysis where we have people with pain at consecutive waves, we're kind of trying to get at those people who are more likely to have chronic pain, with the caveat that, of course, we can't really know about sort of the interwave pain experiences. Okay, so go to the next slide.
Okay.
Is it limitations?
Limitations and directions.
Great. Okay, so yeah, so there are a couple of limitations. Participants had to have 2 waves of data to be included. And as a result, the analytic sample might be somewhat healthier than the ELSA study population, because sort of the sort of people with the worst health are kind of most likely to drop out after having with just 1 wave of study participation. So this has implications for generalizability. Along with that, individuals with worse pain might be more likely to drop out of the study. So results reflect those with less severe pain. So we did see that the follow-up duration was very similar in people with the mild and moderate severe pain group at baseline. But even within the moderate to severe pain group, we may be getting some of the people with the most severe pain leaving the study. It also might contribute to sort of the findings we have for the sort of unintuitive findings we have for age, where we might be getting at a group of older adults that are sort of experiencing pain but are relatively healthy, having sort of this fluctuating pain. As I said previously, we aren't able to distinguish between chronic pain and the other types of pain, subacute and acute pain. But we sort of tried to get at that with the sensitivity analysis, which suggested that the results are probably relevant for chronic pain. We have a subjective measure of pain severity that's just a single question. So there might be, the results could kind of partially reflect sort of norms around reporting pain and that differ between sort of socioeconomic and demographic groups. And the limitation that we always have of ELSA data is that it is primarily white, because this reflects the demographic trends of over 50s during the study period, but it does mean that we need to examine the generalizability of the results in other more diverse study populations, and can't really informatively examine racial and ethnic differences. So with all of that in mind, these future studies should examine the generalizability of results, particularly in more diverse study populations, clarify these differences between acute and chronic pain, and also look at more constructively at causes of pain. We are able to, so we can identify that around 75% of the analytic sample reported back, knee, foot, or hip pain. But within that, there's a large amount of variation. So it would be useful to have a little bit of information. And elaborate the role of treatments and therapies, which we can't really examine with the available data in ELSA. Okay, so to summarize, if we go to the next slide.
Yeah.
So really what these results do is they just reiterate the importance of gender and socioeconomic position. So women have pain that's less likely to improve in severity, less likely to go into remission, more likely to recur. Higher education and wealth mean that pain results in pain that is more likely to improve in severity, less likely to worsen, more likely to go in remission, and less likely to recur. So these findings support policies that promote gender-sensitive strategies. So there's a lot of issues around sort of minimization of pain that women experience by health professionals. So even things like gender-specific criteria for pain diagnostics and guidelines to address sort of the gender biases that in clinical practice that give rise to this sort of minimization of pain among women, and then also pain management that's accessible across socioeconomic levels. So thanks very much. And I guess my next slide is just thanking co-authors and funders. And if there is any time for questions, I'm happy to. If not, that's fine too.
Okay. Well, thank you so much for catching us up. So we're invited to use our emails to go back to the main room to hear the closing remarks from Vanessa. But hopefully people can contact you afterwards if they have questions, Mikaela.
Yep, no problem.
Okay, thank you.
Thanks.